Good afternoon, everyone. At the outset, thanks BNMS for inviting me here. And thanks, Stephen, for making my job much easier. Many things which I wanted to say has already been said, but I will say most of the things in a different context as how we evolved from the initial world scenario of lutetium PSMA treatment and came gradually over to only lutetium, then to the combination treatment and to the targeted alpha treatment. So we'll talk a bit about the initial world scenario of lutetium PSMA treatment, the initial important trials and impact on approvals and guidelines, which many of which has already been said, but we'll still summarize it a bit just to keep the continuum in. The future directions where we are heading to. Is the bubble of theragnostics of PSMA therapy, is it still a bubble, or are we really getting headway with better treatment, better outcomes, and most important, which we always forget, is the quality of life in the patient. So quality of life is very important, which the initial trials probably have not catered to well, and that is a very important factor which needs to be catered. And the future directions would be combination of radionuclide and non-radionuclide or the standard of care treatment, the targeted alpha therapies, and other radionuclides which are in the offing, which are there knocking at the door, but not much data is available. So this is a schema of an interdisciplinary PSMA RLT selection. I'm sure all of us know about it, so we'll not go into the details of it. So if the bottom line is, if the metastases are PSMA avid, we treat with PSMA and we see whatever we have treated. If they are not avid with PSMA, we don't treat with PSMA, we go for other line of treatment. And bone metastasis, soft tissue metastasis, both if they have uptake of PSMA are amenable to treatment. So looking into the initial real world scenario, when we started, we used to get patients who were already squeezed out. They were squeezed out of all the treatments. There was an intense financial toxicity and also the other toxicity as well from the other treatment. So we had patients who had low performance status and mostly ECOG more than 2. So these are the few initial literature which we contributed, and we had a PSA response about 31.2% with a median PFS of 24 weeks. Not bad. We couldn't calculate the overall survival of these patients, but well, we could establish before the every approval that yes, PSMA acts on castration-resistant prostate cancer. It's amenable to treatment with lutetium PSMA, the bony metastasis as well as the soft tissue like visceral metastasis as well. And the initial real-world scenario, the trials which were published, few of the more important ones were in 2016, and where the median radiological progression-free survival was 13.7 months, and another one with a median progression-free survival of 12 months, and median overall survival was 15 months. Now, this is data of the Society of Warmth. That is the Warmth multi-center study, the 617 trial, where we collated data of multiple centers across the globe, and they contributed a retrospective study of their treatment based on a spreadsheet and came to the conclusion that you can see that patients had chemotherapy, the patients, the ECOG status, patients had liver metastasis, the bony metastasis had different types of outcomes. So concluded that the median overall survival was 11.1 months, but what was more important was the patient who didn't receive prior chemotherapy, the overall survival was much more at 14.6 months. So this remained independent in the multivariate analysis, besides the presence of bone and liver metastasis as negative prognosticators of survival. whereas an ECOG 0 to 1, of course, a better performance status was associated with a longer or a better outcome. We have talked about the VISION trial, which actually brought forth the regulatory authorities, the approvals came in so that people across the globe can use it. I'll not go into the details. As we can see here, the lutetium PSMA 617 plus standard of care was much better than the standard of care alone. It improved the overall survival as well as the progression-free survival. So they concluded that in addition of lutetium PSMA 617 to standard of care significantly improved the outcome. Then came the TheraP trial, which was comparing with the cabazitaxel and the lutetium PSMA. And we found a new way of investigating, a new way of selection of the patients in this, where the FDG came into picture, whether we should do an FDG PET scan as well before treatment. It's still debatable in which patients we should do FDG PET scan and which patient we shouldn't do FDG PET scan. Now, what we follow, we generally do FDG PET scan, not in all, but in patients whom the PSMA expression in the metastasis is not as high as it should be expected. That's number one. We do an FDG PET scan in those patients, and in patients where we also find that non-PSMA-avid lesions in the bones, the sclerotic lesions in the bone which are not picking up PSMA. We are not sure whether they are already healed lesions or they are PSMA non-expressing lesions. So in those patients, we do FDG PET scans before the treatment. And I know there are no guidelines in which patients to do FDG PET scan, in which patients not to do FDG PET scan, but this is what we follow. So an adjunct to the TheraP trial, what we came to know was that PSMA PET is a predictive biomarker, but FDG PET is a prognostic biomarker. I think we have all learned about it, that FDG PET positive metastasis in prostate cancer is a negative biomarker or a bad prognostic biomarker. So after these two trials, it came into the guidelines. FDA was approval in 2022, and it came into the NCCN guidelines. The other societies followed suit and put it into the guidelines as well. So did we stop there? We didn't stop there, because as we proceeded, we learned more and more that just the lutetium PSMA treatment, although we could achieve a good outcome, good overall survival, but there can be something more to it. So that's where we evolved into the combination treatment. There are a few trials in the combination treatment, and the first one is the ENZA-P trial. The results of the ENZA-P trials are out and published, and there is also a sub-trial associated with this. So this is an open-label, multi-center, randomized phase 2 trial, which recruited 162 men with metastatic CRPC, and randomization was 1:1. The treatment regimen was ENZA, 160 milligram orally daily, and followed by the lutetium PSMA. The primary endpoint was PSA-free survival, and the secondary endpoint was overall survival and the radiographic progression-free survival, or RPFS. And as expected, the combination treatment, the outcome was much better than the ENZA alone. The adjunct to the ENZA-P trial was overall survival and quality of life. As we say, that quality of life for the patients are very important in all these trials and all these treatment. So the outcomes in deterioration-free survival, the physical function, the combination was 10.6 months, ENZA alone was 3.4 months, and that was statistically significant. So the combination treatment had better outcome in overall health status, the median scores, the COG scores, and the safety profile was also not that bad, as there was grade 3 to 5 adverse events, but it was enzalutamide alone was little less than the combination treatment. The common adverse effects were fatigue, nausea, dry mouth was one of the important adverse effect. So there were no serious adverse side effect. So when they summarized the ENZA-P trial of the 2 trials which are listed here, so the efficacy was that adding lutetium PSMA 617 to enzalutamide significantly improves overall survival and delays the deterioration of physical function and overall health status in metastatic CRPC patients, meaning it also improves the quality of life as well. The safety is a manageable toxicity profile with no new safety signals which was observed, and clinical implication, it supports further the evaluation in phase 3 trials for broader application in these sort of patients. So combination treatment with ENZA-P trial was better, the outcome was better than with the lutetium alone. We know that abiraterone behaves differently in hormone-sensitive prostate cancer and the metastatic castration-resistant prostate cancer. So there is a rapid modulation of PSMA expression by androgen deprivation. So if you look at this patient who is still hormone-sensitive, adding abiraterone to the treatment will regress the PSMA-avid lesions in these. But when this patient progresses to castration resistance, you can see that addition of abiraterone will upregulate the PSMA expression. Upregulating PSMA expression means there is much more uptake of PSMA in the metastatic sites. So can this abiraterone pre-treatment or combining abiraterone treatment, can it be used in a setting where the outcomes can be better? So this is a trial which is investigated, and of course it's a single institution trial. The study objective was to evaluate the impact of combining lutetium 177, PSMA 617 with ARPIs on progression-free survival and overall survival. The study design, of course, was a retrospective single institution study. There were 104 patients, and the groups was combination treatment with lutetium PSMA and the monotherapy with the lutetium PSMA alone. The treatment regimen was 150 to 200 millicuries of lutetium PSMA 617, and the assessment tools were, of course, the statistical tools of Kaplan-Meier analysis. So what was found was the progression-free survival in the combination treatment was 11 months. It was much lesser in the monotherapy. Interpretation was the combination treatment significantly prolongs the progression-free survival as compared to monotherapy. So the concept of upregulation of PSMA with abiraterone in castration-resistant prostate cancer is proved here. So basically now, instead of mono treatment with lutetium PSMA, probably in time to come, we're going to have more combination treatment because initial results have shown that there are lesser side effects with better outcome. Now coming to alpha treatment. Why alpha treatment, first of all? So there are certain advantages of alpha therapy, alpha emitters. The most important is the effects on the DNA. Now, radiation damage to DNA triggers cellular biological effects of radiation. And alpha treatment delivers double or multiple damage sites of break, which is less likely to be repaired. And high LET radiation and high ionization density has more severe and less repairable damage. So it has an indirect effects on the tumors, and it has reduced enzymatic repair mechanism. So this is again a retrospective warmth study of actinium. It's a study design is a multicentral retrospective study of which 448 patients were included retrospectively, and they were treated between January 2016 and May 2023. The locations were 7 centers in Australia, India, Germany, and South Africa, and the patient received a total of 1,174 cycles of actinium PRLT, depending on their own protocols in the different centers. And it was a median of 2 cycles per patient. There were prior treatments in all these patients, and patients received docetaxel, cabazitaxel, abiraterone, enzalutamide, lutetium, PSMA, and they progressed on lutetium PSMA, and even few of the patients received radium chloride, dichloride for bony metastasis. And the metastatic sites included were bone, liver, peritoneal, and others, so soft tissue as well as bony metastasis. So median overall survival in these patients, 15.5 months. Median progression-free survival across all the centers were 7.9 months, and PSA decline of more than 50% were observed in 57% of the patients. So what were the factors which were influencing the outcome of the treatment? PSA decline, no prior exposure to taxane-based treatment, again had a better outcome. Absence of liver or peritoneal metastasis, meaning bony metastasis had better outcome. No anemia at the start of treatment, a better hematological profile, and an ECOG group of less than 2. The safety profile was mostly, as we know, with all the targeted alpha treatment. The xerostomia was almost 68% after the first cycle, and grade equal to or more than 3 adverse events, anemia, thrombocytopenia, renal toxicity in a very few percentage, and leukopenia. There were no serious adverse effect. So targeted alpha treatment, again, had better outcomes, a little better progression-free survival, but again, these are all monotherapy, but the main problem was the xerostomia, which was quite significant even after the first cycle. So the quality of life was severely hampered in these patients. So there are other alpha treatment, alpha radionuclides, which are there, which has been given in this review article on global experience of PSMA-based treatment. There's bismuth, lead, terbium-147, not the terbium beta emitter and the Auger electron emitter, the radium and the astatine as well. So there are certain challenges of all these alpha treatment. So mostly it's the actinium which is the best suitable right now for the treatment as far as the targeted alpha treatment is concerned. Coming to another area is the PARP inhibitor in theranostics. So we know that lutetium induces predominantly DNA single-strand breaks. PARP1 facilitates the single-strand break repair by activating and engaging the repair enzymes. But PARP inhibitors, they increase translation of these single-strand breaks to double-strand breaks with lutetium treatment. So adding PARP inhibitors to this lutetium PSMA probably may again increase the outcome. So this is a replication from the literature of 3 cycles of lutetium due to increasing PSA under therapy with previous hormone analogs and abiraterone. Now there has been dramatic subjective and biological response with significant improvement in ECOG and decline in PSA and alkaline phosphatase with PARP inhibitor. So what does PARP inhibitor do? The most common PARP inhibitor, that is the olaparib, it inhibits the PARP1, PARP2, PARP3 enzymes, exhibits anti-tumor effects by inhibiting the repair of DNA strand breaks, leading to an accumulation of DNA single strand and ultimately the cell death. So PARP inhibitors are, again, another combination treatment, which is for the future. The toxicity profile and other things needs to be still analyzed. So how do we improve responses to PSMA treatment? So when we are biologically targeting these radiotherapy, what is important is the number of receptors expressed on the cancer cell surface. So PSMA receptors, the more the PSMA receptors, better is the outcome. the heterogeneity of the targeted receptor. We all talk of tumor heterogeneity now. And the main idea of combination treatment, main idea of adding some treatment is to counter that tumor heterogeneity and get all the resistant cells also to be effective to the given treatment. The radiation dose to a cancer cell, power and range of internalized radioactive decay, radiation sensitivity of the cancer cell, and how to increase or sensitize the sensitivity of the cancer cell. And there are, of course, many unknowns to deal with. So this is a very busy slide, maximizing how the potential clinical impact of PSMA-targeted theranostics. Again, I'm not going to go to the details of it. What is more important is the dissection of PSMA biology is going to help identify biomarkers for and resistant mechanisms to these treatments and facilitate further therapeutic development to improve the outcome in prostate cancer. So dissection of the PSMA biology is again important, which we need work to do on that in addition to the combination treatment, also to improve the PSMA molecule as such. One thing we must talk about is the dose modulation. That is the tumor sink effect. And what happens is when there is a very high volume of the disease, most of the therapeutic radionuclide goes to the high volume disease, and the normal biodistribution, it's less. But as the patient becomes a responder, many a times the patient becomes a super responder. So in that case, most of the PSMA which has been injected, the lutetium PSMA, or the actinium which has been injected, goes to the normal site. So there is a need to tailor the dose as and when the patient starts responding, meaning in the super responders, the dose should be tailored in a way that there is less to the normal tissues rather than the tumors. So the justification of dynamic de-escalation is important, and as I said, we know that there's a negative correlation between the tumor load and the amount of PSMA uptake in the non-target tissues. The same thing is depicted here in the picture, where you see that the lesser the tumor volume, the more is the uptake in the normal biodistribution. So dose modulation, with keeping in mind the tumor sink effect, is also very important. But all the same, with all these advantages, disadvantages, we know that PSMA theranostics is one of the futures in prostate cancer treatment. And there are isotopes, which are beta isotopes, alpha, Auger electrons. We need to develop more ligands and optimize them. We need to have more radiosensitizers, maybe PARP inhibitors, PSMA receptor upregulation, as I told with abiraterone, which is a very, very nice concept, and immunotherapy with immune checkpoint inhibitors, combining immunotherapy with either pembrolizumab or is going to come. Dosimetry is important, more said than done, but yes, dosimetry is certainly important, and until and unless it becomes clinician friendly, probably it will not be used on the bedside. And PET imaging with PSMA and FDG, we need to find out the indications, proper indications, where we should do an FDG scan as well as a part of the treatment preparation of the patient selection, and radiomics with feature extraction of features, and SPECT imaging with technetium PSMA can also be performed to bring down the overall cost and make it cost effective. So summarizing my talk, as far as we know that monotreatment has a good effect, but the combination treatment, early randomized results are promising. What we need to optimize is dose delivery based on volume and radiation sensitivity. We need to reimagine dosimetry and radionuclide choice. It's important. We need to tailor between the toxicity and the benefit ratio as well. We don't need a good outcome and the patient becoming totally, the salivary glands are totally fired off. So we need to have a balance between these two. It's very important to address the heterogeneity by using PSMA therapy as an adjunct treatment with synergistic combination. That's what the combination treatments are doing. For example, in the ENZA-P trial, ENZA.
Thank you, Partha. Sorry to interrupt, but could you kindly just summarize the end of the slide, because we're going a bit over time, I'm afraid.
Yeah, this is the last slide. Lutetium PSMA is secondary and used to reduce the population of AR-resistant cells. I need to understand the biology of PSMA well to move treatment effectively into an earlier space. And the targeted alpha treatment represents a viable therapy option, including those previously treated with other agents. Thank you for your attention.